moving on to the next section of subclinical hyperthyroidism. Now let us start with a case, a 67-year-old lady who's been referred to us for a goiter which has been noticed 2 years back. She's been menopausal for about 17 years with no comorbidities, and her TSH is 0.03, which is much lower than the normal cutoff of the assay used for measurement, and the free T4 and the T3 is normal. So like subclinical hypothyroidism, this is again a biochemical diagnosis where only the TSH is suppressed, the other two values, that is the T3 and the T4 values, are normal. Now also again here we need to differentiate between hyperthyroidism and thyrotoxicosis. So thyrotoxicosis is a situation where there is toxicity or biochemical levels of thyroid hormones are elevated, and hyperthyroidism is a situation or is a cause or one of the causes of thyrotoxicosis wherein the thyroid gland itself is hyperactive. So a biochemical picture like this can happen due to a number of reasons. Number one, the thyroid gland itself might be the one at fault which is causing the suppression of the TSH because of slightly more than normal production of thyroid hormone levels, or it could be iatrogenic, where we are treating someone with levothyroxine therapy and inadvertently have given a higher than normal required dosage, or it could well be factitious as well, where the patient himself is consuming medication and this results to this abnormality. Unlike subclinical hypothyroidism, subclinical hyperthyroidism is much less common a problem, and like the hypothyroidism as well, this is more likely to be in women and older individuals, smokers, particularly in people who are living in mild to moderate iodine deficiency area. In terms of etiology, I've already talked about the exogenous and the endogenous. Exogenous could be unintentional, like over replacement therapy with levothyroxine, or intentional as part of either factitious or as part of a suppressive therapy for a goiter, for example, or even for thyroid cancers. And the endogenous ones would be Graves' disease, toxic multinodular goiter, toxic adenoma. It could be part of a thyroiditis, or it could be part of pregnancy or HCG induced problems during pregnancy. If you look at the natural history, it could well be that this kind of subclinical hyperthyroidism might persist for a very long time, or only rarely it might progress to overt hyperthyroidism. So you can have both of them. Therefore, in a big proportion of patients, we are probably justified in just waiting and following up patients. Now, what's the problem if you have such a biochemical report? There can be some systemic effects, including effects particularly on the cardiovascular system and the bone. In the cardiovascular system, it increases heart rate, increases the risk of arrhythmias, increases left ventricular mass, and might lead to increased consumption of oxygen and load on the body, increased BMR. And as I had shown in one of the previous slides, there is probably a relationship between suppressed TSH levels and survival. So we don't want the TSH to be suppressed too low, because we know that such individuals are probably likely to have problems and increased cardiovascular mortality. In terms of the musculoskeletal, osteoporosis, problems of decreased bone mineral density, problems greater in the cortical than trabecular bone, more so in postmenopausal women, might lead to increase in vertebral and hip fractures and also decrease muscle strength. So there can be profound effect on the musculoskeletal system. In terms of the central nervous system, there might be some association between dementia and subclinical hyperthyroidism. However, causality has not been established. Quality of life also can be impaired, and there might be problems of palpitations, sleep disturbance, effort intolerance, and mood changes. Now, how do you approach a patient when the patient comes with such a biochemical problem? The first could be that this is a patient of Graves' disease. The patient might have become euthyroid, but the TSH might remain suppressed for years together, which has no clinical implication, and the patient might just be followed up. The second group of problems can be subclinical hypothyroidism, and the third is CQ thyroidism. And if you are looking at etiology, if there's a past history of a sore throat or a fever, you can think of subacute thyroiditis. The orbitopathy might give you a clue to Graves' disease, and even the bruit might give you history or suggestion that what the cause might be. And in a pregnant woman, a history of missed period is going to clinch the diagnosis of HCG mediated suppression Now, in terms of investigation, you can do a radioiodine scan or a technetium thyroid scintigraphy to see whether this is a case of thyroiditis or exogenous excess or even an endogenous problem to look at Graves' disease, toxic adenoma or toxic multinodular goiter. The serum TG will probably only help us in individuals where you are considering factitious hyperthyroidism. You have to look for other comorbidities including history of fracture, cardiac disease and menstrual history is required. And if you look at the flow diagram, this kind of summarizes what I've already talked about. And if you see the TSH is less than 0.1, you should probably ask for a scan. If it's between 0.1 and 0.5, you can wait and watch, repeat the test. If it normalizes, fine. If it doesn't, then go for a radioiodine scan. Once you've done the scan, if the uptake is low, it could be subacute thyroiditis or even factitious. If it's diffusely high, it's Graves' disease. If only one focal point is increased in uptake, it is toxic adenoma. Whereas if there is multiple areas of increased uptake, then it is a toxic multinodular goiter. Having diagnosed the problem, you now have to manage the patient. First of all, because we've talked about that it has effect on bone metabolism, ensure that the patient takes adequate amount of calcium and vitamin D. And in terms of exogenous hyperthyroidism, reduce the dose of levothyroxine that you were using. Suppressive doses of levothyroxine, if you are using, try and cut down on the dose and keep the minimal possible dose to achieve the TSH in the particular clinical scenario that you're trying to manage. In terms of endogenous hyperthyroidism, we have very little data. RCTs are lacking, and mostly what I'm going to talk about is based on small studies and expert opinions. And if you look at the factors which will determine whether you will probably consider treating or not treating, one would be age. Older the individual, more likely you are going to treat. So anyone above 65, you're probably going to treat if the TSH is less than 0.1, and you will consider treating even if the TSH is between 0.1 to 0.5. Whereas in younger individuals, you will probably be treating if they have other comorbidities, predominantly with heart disease, bone problem, postmenopausal, or if they are having symptoms of hyperthyroidism. However, if they are young people and asymptomatic, you will probably be having a greater threshold at which you would probably be treating individuals. So if you are going to treat, what treatment do you do? Coming back to our patient who had a multinodular goiter which was non-tender, heart rate of around 90, repeat thyroid function test suggested persistence of hyperthyroidism, a scan showing a toxic multinodular goiter with osteoporosis on the BMD scan, radioiodine ablation was done in that individual, calcium and vitamin D supplementation was done. Subsequently, the patient developed hypothyroidism which was then treated, and there is improvement of BMD at 2 years. So I shall stop there and hope you've enjoyed learning as much as I have. Thank you very much.